Okay, so good morning, everybody, and welcome to the University of York and to our Health Economics Policy Seminar Series. My name's Susan Griffin. I'm the co-director of the Real Supply Unit. We're funded by the Health Foundation, and this supports us to do some work in economic research to support long-term resilience and equity in supply of health and social care. Through our work and our events like this, we want to bring together members of the public, researchers, and people who are working in health and social care to spark some discussion and to inform our research. And that brings us today, and we're delighted to be continuing a conversation around adult social care and the workforce. And so I'm going to introduce another member of the Real Supply team, Steve Allen. He's the co-lead for social care within our research unit, and he's going to be chairing this seminar and introducing you to the speakers. So Steve, if you'd like to come here.
Thanks, Susan, and good morning to you all. I'm delighted to be able to introduce you today to Oonagh Smyth, who is the CEO for Skills for Care, which is a strategic workforce development and planning body for adult social care in England. Now, Oonagh's had great influence in and dedication to social care for a great number of years, with previous roles including being the Executive Director of Strategy and Influence at MenCap, had senior roles with Northern Ireland Council for Voluntary Action and the National Council for Voluntary Organisations, and has also served as co-chair in the Care and Support Alliance, amongst a number of other roles. Oonagh's talk today is on meeting the future challenges facing the adult social care sector. Following the talk, there'll be opportunity for some questions and answers, so for a general chat about what Oonagh has talked about today. So for those of you online, please do submit your questions in the Q&A section, and they will be mediated and asked following the discussion. So Oonagh is uniquely positioned within her role and her experience to be able to lead us today in looking at the essential policy steps that are required for being able to support the workforce to help support those with care needs as we all are growing older in this ageing population. So I'm delighted to be able to welcome Oonagh Smyth.
Thank you, Steve. So as Steve said, Oonagh Smyth, the CEO of Skills for Care. Let me tell you just a little bit about me and how I've ended up in this role, just kind of introduce myself. So you can probably tell from my accent, I am Belfast born, and started thinking that I wanted to go into law and be a lawyer way back in the day. My sister was born with spina bifida, and she died not long after she was born. I never met her, but she was always kind of in our family, and we spoke about her quite a lot. And when she died, the nurse at the time said to my mother, "Don't bother naming her. You'll have other children. There's no, just move on." And that kind of presence in absence kind of shaped my family in a way. We did a lot of voluntary work. I volunteered for what was called the Gateway Club then during my levels, working with adults with volunteering with adults with learning disabilities. And I absolutely loved it. And then thought I wanted to go into law, went into human rights, worked my way right back to learning disability in MenCap, where I joined together my kind of policy background, my kind of legal side and learning disability, and then worked there for MenCap for about 8 years, and then I've been in Skills for Care almost 6 years now. So started in March 2020 with excellent timing. Started on the 9th of March, got COVID on the 13th of March, had to close down my office and get to know the organisation quite quickly. So I'm going to speak for about 45 minutes today, and then we've got about 15 minutes for questions, and I'm going to use quite a lot of data. This data is just off the, it's brand new, we only released it yesterday, so if anybody joined the webinar yesterday where we launched our state of report, then you might be a bit bored because I'm going to use quite a lot of the same information. So Skills for Care is, as Steve said, the strategic workforce development body for social care in England, and this just gives a sense of what we do. So we sit at that intersection between policy and practice. That's what we try to do. We try to use practice to inform policy and bring policy into practice. We have national and local presence, so we are in all local authority areas. We have about 25 years of experience in workforce in that space between social care and skills, thinking about all things workforce, really. And one of the things that we did recently was launch a national workforce strategy for adult social care in England, and I'll talk a little bit about that later. The data that I'm going to talk about today, we can gather because of these relationships and because of the trust and the credibility that we have. So our data set is built from, we have 700,000 individual staff records on our data set. So it's a really high quality data, which is excellent. Move on to, so before I get into the kind of workforce context or the what's happening in workforce, I wanted to start with the kind of wider system challenges, because we know that workforce is really important, but quite often the issues that we might see with workforce start further up and start with bigger systemic issues that then impact the workforce later. So I wanted to talk a little bit about some of these, what we think are the wider systemic challenges for adult social care. The first is the kind of lack of understanding of social care with the public, really. People think social care is free at the point of need until they get into the system. They undervalue what social care is, what it does. Social care is a workforce that is primarily female, primarily or disproportionately staffed by people from the global majority. We support disabled and older people, and so there is often a lack of value for this workforce, and that feeds into the sometimes the lack of priority that the public will give social care. When we talk to people working in social care, more than half of them say we don't feel valued, we don't feel understood, people don't appreciate our roles, and that has an impact both in terms of being able to attract people, but also in terms of being able to keep them as well. But I think there are opportunities to talk about social care differently. We are a sector that is, you come to work in social care and there will always be a job for you. This is a growing workforce, it's a growing need, it's really valuable. People enjoy it when they work in social care, they get real value from it, there's a lot of flexibility. We need to have a slightly different conversation about the workforce. Sources of funding are quite fragmented, and that then impacts the ability to plan in social care. So we've got so many different funding streams: local authorities, Better Care Fund, continuing healthcare, local authorities, self-payers, and all of that can result in quite a complex picture, difficulty planning long-term, difficult to plan capital investment, all of the things that we know need to be happening, and that then impacts on the overall sector. It can also make it quite difficult to get stable investment into the sector. So things like pension funds investing in social care, or we don't see that as much because it's not seen as a kind of stable enough sector. And then thirdly, and this one I think is something we really need to be aware of and plan any change around. The levers for change, the levers in social care are so dispersed. So at the minute we've got 19,000 social care providers, 153 local authorities. We've currently got 42 ICSs, at least 2 government departments that have a real interest in social care, and that's not accounting for Treasury and DWP and DFE. We've got a number of regulators and all of those bodies have slightly different levers, and we need to make sure that we are working to pull those in the same direction. That's one of the things that we tried to do with the workforce strategy. And then that final point, which I will talk about a little bit later, the sector itself is large and complex and fragmented, so 19,000 providers, and that story within the providers is very different. So we've got 37% of providers that employ between 1 and 4 people, so really, really small organisations. 85% of the sector, I think it's 84% now, are SMEs, so employing fewer than 50 people, but we've got 2% of providers that employ almost half the workforce. So we've got a lot of very small providers, and then we've got a very small number of very big providers. So trying to have any consistency in terms of models of care, in terms of data, terms and conditions, communication can be really difficult in that wide sector. Let's talk about how that kind of plays out in workforce terms. So yesterday we published the State of the Adult Social Care Sector and Workforce in England report, which we do every year around this time. And all of that is available online for you to have a read of the report, and there's various data visualizations, and you can play around with it and compare different regions. The data is reliable at a local authority level, at an ICB level, and then we've got it nationally. Any lower than that, you kind of lose the reliability, but it's incredibly robust. It's got 700,000 staff in over 21,000 locations. And this slide is just really to convince you of the rigor of the data before I move on to what it tells us. So the Office for National Statistics described our data set as the most comprehensive publicly available source of workforce data for the adult social care sector in England. And the way that we build it, so this little point that we're trying to make here, this isn't mandatory for providers to fill in. Local authorities have to fill in the data set, so it's we get 100% return for local authorities. So everything that we know about local authorities is really reliable. For independent providers, they don't have to. So we try to build the service in a way that providers find helpful. So we get their information, they trust us with it, we're able to analyse it, we're able to influence policy with it. But what they get is the ability to benchmark against other organisations locally, so they will know we pay more than a similar provider locally, we pay less, we have higher turnover, we have lower turnover, so they're able to do that benchmarking. It also gives them a training record that they can then use and pull down for regulation, or reminds them somebody's mandatory training is done. So we try and build it as a service so that it's really helpful for people, because we know we've got an incredibly time poor sector, and to ask them to give us their data doesn't come free. So just a quick note on methodology, just for certainty is not the right word, but we don't include social care related roles employed by the NHS, and we've gone back and kind of redone our stats over the years so that we're able to still look at trends, and that's really to avoid the risk of double counting. And we have also automated some of our data pipelines so that the full post estimates that we have are more rigorous, and we've again gone back and changed some of the previous year's data. I say that in case somebody is sitting there thinking, oh well, in 2022 your data was X, or your stats were X, and why is that so different? And I'm not sure anybody would have that detail, but just in case, I wanted to include that. So let's get some of the headlines. The kind of big picture is that the story is quite complex. On the one hand, we have seen the workforce grow for the third successive year. We've seen a reduction in vacancy rates. Vacancy rates are now down to kind of pre-pandemic levels, and we've seen a reduction in turnover. We have also seen the demographics in the workforce shift. So I sort of caught myself. So the proportion of men in the workforce is now the highest that we've ever seen at 22%. A lot of that's down to international recruitment. International recruits much more likely to be men. And a lot of these vacancy and turnover rates are down to international recruitment. We've seen a lot of international recruits coming in over the last few years, although that has started to reduce, and I'll go into a little bit of that later. We are also seeing the number of British nationals joining the workforce reduce, and that's really important because it's reducing at the same time as international recruitment is reducing and demand is growing. So we need to come back to that. We are also seeing, in this final point, the level of qualifications among care workers reduce quite a lot. So the reduction in the number of care workers with a level 2 qualification. We used to have 48% of care workers had a level 2 qualification. That's now down to 38%, and that's quite a shift since 2018-19. There's plenty happening to tackle these challenges. The workforce strategy is one. The care workforce pathway, which some of you might be aware of, which is trying to clarify and make clearer the pathways that people have through their careers and the qualifications and the competencies that are needed. The fair pay agreement, the conversations around the National Care Service. But I'll talk to you a little bit about some of that later. Oh, sorry.
Could I just ask a question about interpretation? So vacancy and turnover rates are falling. The increase in internationals is being matched by a decline in nationals, and the level of qualification is falling. So is this a story of the quality overall is going down? That's how the gap has been met, by reduced quality and reduced staffing.
So what we are seeing is capacity isn't the big issue at the minute. It's not a kind of big vacancy rate, big turnover. But we are hearing from providers. I'll go into the qualification rates a little bit later. That what are some of the reasons that are driving that reduction in qualifications? Providers will tell us that they are finding it harder financially, and they're having to prioritise mandatory training over longer qualifications. They would also say that the qualification landscape is quite complex as well. And some of the changes are going a little bit to apprenticeships and the fall in apprenticeships, which I think is feeding into some of this. But some of the recent changes making apprenticeships a bit more flexible, we might see that shift change again. But the overall reduction in both international recruitment and domestic recruitment, unless we do something, we might expect to see capacity issues again. But I'll go into some of that when I look at the skills landscape. So the size of we released some of this data earlier in the year, so I won't spend too long on it. But just to say, this is a big workforce. This is a workforce that is bigger than the NHS. We have 1.6 million filled posts. That's made up of 1.5 million actual people, and the total number of posts is 1.71 million. So that's the 1.6 million plus vacancies makes up the 1.71. This is an increase of 52,000 filled posts. So we're seeing the workforce grow. It's smaller than the previous year in terms of growth, but it's still sizable. That equates to about 111,000 vacancies and a 7% vacancy rate, which again is closer to pre-pandemic rates, but is still 3 times the national vacancy rate when you look at the broader economy. Social care is still a significant economic contributor, so contributes just under 78 billion to the English economy, and that is an increase of about 12% from the previous year. And that increase is down to the workforce growing and the national living wage growing. That accounts for that increase. I talked a little bit about this at the beginning. We have seen an extra 500 organisations in the year in social care, so about 19,000 organisations in social care across 42,000 establishments. I talked a little bit just about the makeup of those organisations in terms of small, medium. Most of the workforce is employed on a permanent contract, and managers, senior care workers are more likely to be employed on a permanent contract than care workers. 57% work full-time, but that compares to about 3/4 of the broader economy where people work full-time. So we are more likely to have part-time staff in social care, and some of that is because of the nature of the work that we do, the changing nature of people's needs during the day. Some of it's personal preference of individuals, and some of it is the lack of stability in the market. It's all of those things playing in. Most registered managers, most senior managers will work full-time. Personal assistants are the least likely to work full-time, so only about 14% of personal assistants work full-time. And then COR's contract is a really important dynamic in our sector. So 21% of the workforce work on a COR's contract, but in home care that's 42%, so almost half the workforce on a COR's contract in home care. And people on a health and care visa are less likely to be in a COR's contract, and that makes sense given the restrictions and the rules on those visas. We have some new insights into the workforce this year from the data set. So we looked at broader terms and conditions, so pensions, sick pay, and annual leave, and we found that most of independent providers pay the minimum towards a person's pension. So in March 25, 43% contribute more than the minimum 3% to care workers' pensions, but that 99% of care workers in local authority sectors had more than a 3% contribution into pensions, whereas only 30% in independent providers had more than a 3% contributions. CQC care homes with nursing were less likely to contribute more to pensions, so that only 16% in our data. And then sick pay, 38% of employers pay care workers more than statutory sick pay. And in local authorities, 91% of care workers employed by local authorities are paying more than the statutory minimum sick pay, versus 26% of independent providers. The annual leave, 28, the median days are 28. That's the legal kind of minimum is 28 days. Local authority employed full-time care workers are more likely to receive more than the minimum. This is particularly important when we start to look at turnover rates. So we see turnover rates reduce where employers pay slightly more pension, more statutory pay. So that feeds into the kind of terms and conditions, quality of role element of the workforce. So turnover, again, I've kind of talked about this. Turnover's down. The starter rate is down as well, but we would expect that because if you're not losing as many people, you don't need as many people to start. So that kind of feed into each other. And we've got a kind of core of experienced staff with average experience across the workforce of 9.3 years, although that's been slightly reducing in recent years. Workforce demographics, I've talked a little bit about that. I'm going to come back to some of that. I'm sure some of that will come up in the questions. So if we start to look at pay, so we have a whole chapter just looking at the kind of pay profile of the workforce. The median care worker hourly rate in March 25 was £12 an hour, and that at the time was 56p above the national living wage, and that's a £1 nominal increase since the March the year before. But care workers still earn less than NHS band 3. So when you compare across those sectors, NHS band 3 workers start at £12.67 So that's and band 2 workers start at £12 and 8 pence. The pay differential is really important to note. So a care worker who has 5 or more years experience will get on average 7p an hour more than somebody who has started today. So that might be 5 years, might be 15 years experience, might be 25 years experience. Those differentials have been squeezing over recent years. So in 2016, that figure was 33 pence an hour. So there was 33p an hour difference between the most and the least experience, and that's been reducing as the national living wage increases. And then just 2 other things to note. We have seen an increase in the proportion of staff that are paid at the national living wage, at the floor, really. So it used to be we had 18% of the workforce that were paid at the national living wage, and that's now 23% paid at the national living wage. And we also, when we look out at the wider economy, social care workers are paid less than 80% of other roles in the economy. So still quite significant when we look at that broader comparison. And then just to pick up the qualification point and what that's telling us. So we have seen a reduction, as I said at the beginning, of about 10% in care workers with a relevant qualification at level 2 or above. And that's not to say that qualifications are the only way to get and show competency. People can get competency in social care by experience, by shorter skills, shorter learning and development. But qualifications are still a really important way that we build the workforce, that we support them to do the roles, that we give them the confidence, that we give them the skills. And it also, qualifications play into turnover rate. There's a relationship between the more the workforce is qualified, the less likely they seem to be to leave. And we don't know what that relationship is, but we can see that correlation. So let me just pull that out. So qualified care workers, 21% of qualified care workers left in the last year, compared to 27.2% where they don't have a qualification. It's quite a significant difference, really. And that's not to say that people aren't doing training. We had 81% of the workforce that completed non-statutory training. So people are still training, but just not necessarily the formal qualification route. And then picking up apprenticeships. This has been a story over a number of years. So since 2016, we've seen more than a 75% reduction in apprenticeships in social care. And in the last year, we saw a 5% reduction, and then 31% since the kind of COVID year. And that we hear from providers that there's a number of reasons for that. There's a supply issue. So if you do an apprenticeship in social care, a provider will get about £4,000. Well, that's 11,000 if you do an apprenticeship in hairdressing, and it's about 7,000 if you do an apprenticeship as a cleaning operative. So we've seen in the year 200 learning providers stop providing apprenticeships in social care because they can't make it work economically. So there's a supply issue for apprenticeships. We also hear from employers 2 things. The time off the job, the learning time, without backfill, people can find providers can find difficult, and they would also say that the apprenticeship is too close to the diploma, and so what they will prefer to do is to support people to get the diploma who then don't have to do the endpoint assessment in the apprenticeship. And some of that will change with the new flexibilities with apprenticeships, but that's kind of the current landscape. So I think this is quite an interesting bit of analysis where we've looked at the career progression in social care. So we've looked at the data set between 2010 and 2025, and one of the things that I found quite interesting is one of the most common movement in the sector is from ancillary staff, so maybe kitchen staff, cleaning staff, reception, into care worker roles. And in social care, I don't think we talk about that enough, that often people won't think about doing direct care provision, but when they come into contact with social care, they really like it and they'll move into those roles, because the pay is very similar. So it's not primarily a move, a pay related move. It's something deeper where people are finding that experience, and they enjoy it, because the difference in pay is quite small. The care workforce pathway that we've been working on with government, we've now got on to the adult social care workforce data set, so we'll be able to look at the different roles and how they manifest in the sector, and what that looks like and how people are moving between roles. So we'll have that analysis in future years, hopefully next year. And then just looking out to the future workforce projections. So feeling really conscious of my audience here with all of you experts. What we do here is a very simple projection. It's not a prediction. It's really looking at over the next 15 years, if the workforce grows at the same proportion as the over 65 population, what would that start to look like? And what it tells us is that we will need 470,000 additional posts in social care over the next 15 years. Now, that is just a base case. That doesn't take into account any policy changes, any technological changes. It also doesn't tell us about the younger population that's coming into social care, because we can't see that, and I think that is notable. We need to think about that, because as we see people coming, children moving through the children's social care system, we don't have a sense of the scale of those needs and how that's going to manifest in social care. And while I'm doing all those caveats, we also go back and look at those projections compared to the actual growth in the workforce. And over the last 10 years, it's been pretty spot on, actually, other than the workforce grew a bit more during COVID than we had expected, because, you know, who could have expected that? But it has been a pretty good indicator of the workforce growth over the last few years. And that's about a 27% increase. And there is something about the really thinking about this figure and how we get it over the years to be more accurate. It doesn't take into account turnover. It doesn't take into account policy intentions. So I think there's a conversation that we need to have around building on our kind of understanding of those projections. We've done a bit of a deep dive into international recruitment this year. We did it last year as well. So in 24-25, we had 50,000 people arrive in the UK and start in direct care providing roles in the independent sector. That is down from 105,000 in 23-24, and it was 75,000 in 22-23. Now, within that 50,000, 10,000 came from the health and care worker visa, and 40,000 arrived through other routes. So that includes student visas, it includes dependents, family members. Where it's recorded, it's not always recorded, but where it is recorded, over 95% of international recruits came from non-EU countries, and most commonly India, Nigeria and Zimbabwe. And meanwhile, we saw posts filled by British nationals fall by 30,000 in the year, and by 85,000 since 21-22. And I just want to make this really clear, and we have made it clear in the report and in our press release. This isn't about international recruits displacing British workers. There are 111,000 vacancies. There's a lot of vacant posts in social care. This is about the roles not attracting domestic workforce, and that is something that we're going to have to be aware of, because international recruitment is reducing and domestic recruitment is reducing. So we're going to need to think about that pipeline for the workforce as that demand grows. We do some, I think, really interesting analysis of the factors that most affect turnover, and we have a whole list of factors that have an impact. Things like if somebody lives closer to their workplace, they're less likely to leave. If your registered manager leaves, your turnover increases. If you've got a stable registered manager, your turnover reduces. So some really interesting factors. If new starters are more likely to leave in the year, so that type of thing. And I'm going to pull out in my next slide the kind of 5 main factors, but what we see is 34% of people leave in their first year. Sometimes that's because they just haven't understood the role, and they come into social care and they think, oh, I don't think this is for me. Sometimes it's their experience with a manager. Sometimes it's because they're working short-term in social care before they go to university. It's just lives, really. So there's a whole variety of factors that will be impacting there. But that's compared to a much lower turnover rate for people with significant experience in social care. And then we see lower turnover rates for people who have been recruited internationally. And again, that makes sense, given that often the visas will link them with organisations, and if they've come in through that visa route, they'll be less likely to leave. So we've combined these what we call the 5 kind of positive factors for that impact on turnover. So if you're paid up to 30% below the local authority average, if you've got guaranteed hours, if you receive training, have a qualification, and are working full time, if all of those factors are in place, turnover is 14.4%, and if none of those factors are in place, turnover is 42.2%. So what we've tried to do is look at the kind of cumulative impact of some of these factors, and there's no kind of causal link. These are just the things that we can measure in the data set. But what this tells us, alongside another piece of research that we have done, which is quite out of date now, but we're just about to repeat it, where we looked at the care providers who have the lowest levels of turnover. So we have about 16% of providers that have turnover of less than 10%. And we asked them, what is it that you do that's different? And what they told us is they didn't actually mention pay, they didn't mention terms and conditions. They said, we give people maximum autonomy, we live our values, and we say thank you. And we invest in leadership. So when we join together some of that research with some of this data, we can see that the 3 factors that are incredibly important in terms of turnover are quality of role. So that is pay, that's terms and conditions. It's the balance between flexibility and stability. Learning and development is also really important, and then organisational culture and leadership. And they're the three factors that will have most impact from what we can see in terms of turnover rates. And then we also see CQC quality ratings linked to workforce stability. And again, we would probably all guess some of that, but it shows up in the data where we have residential homes with more staff per bed. We see better CQC scores. Where we have higher pay, relevant qualifications, and lower turnover, we see better CQC ratings as well. Again, we don't know about the causal link between those things, but we can definitely see that in the data. I am nearly finished, and I'll open up for some questions. So one of the things that we've tried to do in Skills for Care is to say, we need a 15-year strategy here, really, to pull together the different levers in social care. There's not one body, there's not one organisation that has the ability to deal with the growing need, the growing challenges, and to make the best use of all of the opportunities that we have. And so what we've done is a 15-year workforce strategy, which pulls together as many of the different partners as we can. And we were very clear that all we could really do was plan within the current paradigm. So we've planned within the current system, but recognising that we will need and will have, coming from the KC review, a reform or a transformation plan for social care, and on that we will have to go back and replan the workforce, because the workforce will probably look different in terms of that transformation. And what we're trying to do is to say there's a lot of change that we can make and lead within the current system, and there's stuff that we just all need to get on with, and that's great. And then there are things that we need to be thinking about longer term in terms of reform, feeding into that Casey review, feeding into government, and there's opportunities to do that. So I'm going to, I think I've got a little QR code that I can just pop up at the end if you want. So there's a whole range of recommendations, some sector led, some only the government can deliver, some already in train, and that we're trying to keep kind of momentum up, because there's a lot to do. I'll give you just a little bit of a. So the workforce strategy is broken down into three main areas: attract and retain. So that covers a lot of the stuff that we've talked about today. So pay, terms and conditions, some of that covered in the fair pay agreement. 10-year attraction plan, which I think is something that we have yet to start working on. And when we look at the question that was asked around what does that start to look like in the future, if we're seeing international recruitment and domestic recruitment reduce, if we're seeing qualifications levels reduce, how do we have a more strategic approach to attraction? I think that's going to be really, really important, and that's a kind of outstanding recommendation. And then we've got a whole range of things that are happening around regulated professionals. So if we like to call them the small but mighty part of the workforce. So we've got 925,000 care workers. That's a lot, and we've got about 6% of the workforce that's made up of social workers, nurses, registered managers, and are so key to our services, key to cultures, assessments, personalised support. So trying to really put more joined up working around those parts of the workforce. And then the second area is training. So you wouldn't expect a workforce strategy without a focus on training. And this is really thinking about career development, having a kind of clear pathway for people to see how they move from their current role into future role, or how to develop in their current role. Not everybody wants to move. And then some actions around how we improve the quality of training, how we think about apprenticeships, and given that big reduction that I spoke about. And then transformation. So that kind of how do we, what does that future look like for social care, and then how do we think about the workforce in the light of of those new skills. We're doing a care technologist pilot at the minute, which is looking at what is the role of technology in care. What does that mean for skills? What does that mean for separate roles? There was a similar pilot in Scotland with some quite interesting findings. People are quite excited about this. And then thinking about digital skills in the workforce, and how we build people's confidence, because that's going to be a really important part of what care looks like in the future. And then if I just finish with a few of the policy initiatives that are currently underway, which I'm sure we want to talk about. The Fair Pay Agreement is one, quite a significant one. So we have had a recent announcement from government of a 500 million investment into the Fair Pay Agreement. The Fair Pay Agreement's out for consultation at the minute. If people haven't seen it, I think it's open until January, so you've got some time to feed into that, and it asks questions around scope, around infrastructure, and I think that's going to be an incredibly important consultation, and the sector is going to want to get really engaged in it. There are big opportunities in terms of addressing the low pay in the sector. It's a chance to link pay with progression, so that we're not seeing those differentials squeeze, and a potential to address and think about broader terms and conditions. But of course, there are challenges as well. There are funding challenges. We're hearing this from the sector. We will need significant investment to make an impact, and there are risks of unintended consequences. We know this in social care. It's a bit like whack-a-mole. You make one change over here and something else pops up elsewhere. So trying to think about the unintended consequences of some of that will be really important. And then just this final point, while pay is important, it's obviously not the only thing. And we know that other sectors will respond to an increase in pay in order to attract people into those sectors. But where we can compete is around purpose and flexibility, and the things that social care does really well that we should be making more of. Neighbourhood health is a huge opportunity, I think, for social care. If you think about social care at its best, is neighbourhood based. It's personalised, it's preventative, it focuses on well-being. That's exactly the kind of philosophy of neighbourhoods, and it's a chance to really build support as close to people's homes as possible. There are challenges in terms of making sure that social care it comes in as an equal partner. We have a lot to teach as well as to learn. We see people's needs through the lens of their whole lives, as opposed to the lens of one or two particular needs. I think we've got quite a lot to bring into that space. So we need to be there as a kind of confident partner. We also need to make sure that the workforce has the right skills in order to play that role. So there's quite a lot of work going on at the minute with delegated health tasks, and making sure that the workforce has the skills, but also that funding is moving to support that increasing delegation, and that we've got the right clinical supervision in place. So big opportunities. And then we've got the Baroness Casey work around the National Care Service, which is intended to really think about the broader system issues and what that medium-term changes look like. So that she's going to report in March 26 about the medium-term changes, and then in 28 about the longer-term changes, so that more paradigm shift. So there's a real opportunity, I think, for us all to feed into that. Obviously, the difficult decisions will need to be made about funding is doing quite a lot of heavy lifting in that slide. But there are of course challenges in terms of the what that starts to look like, and some of the debates that we need to have. So that is me. We've got some questions. Thank you for that.
So no, that's a wonderful talk and description of the state of the workforce as it stands, and thinking about the challenges that we face and the potential policy avenues that are being talked about. So yes, are there any questions from the audience? Yes.
Thanks so much. That was extremely useful for our work. So myself, Francesco, and Andrea, we're part J, but we're funded as a part of the policy research unit for the Department of Health and Social Care. And a section of that programme of work is looking at trying to provide some causal estimates of the more complete picture of the value that changes in expenditure in adult social care has. So we've got causal estimates on the users and carers' quality of life. We've got causal estimates of the impact of adult social care spend on NHS outcomes, and also on measures of local pay production through GVA. And all that work is pointing to the fact that, probably no surprise to you, that actually bloody good value compared to the Treasury's valuations for all these outcomes. So we're trying to put together that picture to tell a story that actually investing in social care is not a burden. It's actually really good use of public money. What we haven't done, and what this is starting to suggest we could do, is to start to pick apart how those causal paths are influenced by workforce issues. So at the moment, we've just got the effect. Some of that effect is mediated through workforce aspects of workforce. With this data, we might be able to tease those apart. So we might be able to identify the effect of a changing workforce quality, however measured, for example, turnover, etc., on those outcomes. And I guess my question to you is, number one, can we get these data at a local authority level? And number two, the other thing I think will be quite interesting will be to look also at the type of provider And do you have that available at a local authority level? And if the answer to both those things are yes, would that be interesting?
So we do have this available at local authority level. And so by type of provider, what do you mean? Do you mean voluntary sector, or do you mean type of provision?
I was thinking about two things. I was struck by the fact that the data on workforce employed by the local authority is very different to those not employed by the local authority. So that's kind of interesting. So it poses the policy question, will we better employ people through the local authority? Is that worth it? We're going to spend more, but maybe we'll get better outcomes. The other thing that struck me was that there seems to be massive heterogeneity in the type of provider. Outside a local authority area, you said that 2 providers cover
2% of providers employ about half the workforce.
exactly. So
We've got a lot of small providers.
So I'm just wondering whether type of provider might also be something worth looking at.
So we on that point, we did I was very interested as a newbie when I first came into Skills for Care on the data, and I asked the team whether the kind of size of organisation was a key variable in terms of workforce outcomes, and it didn't seem to be. So the team did the analysis, and they didn't seem to find that the kind of type or size of provider had an impact. Obviously, that's just the kind of size. That's not the case when we start to look at the difference between home care and residential, because there are real differences there. Even in terms of COR's contracts, we see 42% of the workforce in home care and COR's contracts. So that's quite different. But the size of provider didn't seem to be a key variable for things like turnover. But yeah, I'm around after if you're around to pick that up.
And if you've got more questions,
Nick Bosenkamp, I think I'm one of the few people around who were involved in social care in the 1960s with Peter Townsend and others. I was actually a member of the J Committee in the 1970s, which did actually a very good job in designing a social model of care. What I like about your talk is that it does have a lot of hidden optimism behind it. And certainly, if you compare the situation now with the situation in the 1960s, there's been a tremendous amount of positive change with a lot more choice, a lot more services, a lot more support going on. But what we need to do is develop home care services more. That's the big priority in the next few years, because there's now a larger health medical element in the kind of people who are needing support at home. So we need more integration with the health service and joint working through neighbourhood care, which I think are tremendous new option for social care. And there's already been a shift from care home care to home care. Everybody expected back then that the number of care home places would continue to rise pro rata of the population. That has not happened. There are 50,000 fewer places than there were 15 years ago, even though the population namely need has increased. And that's because there is more home care, something that's been developed quite informally, not with very much government responsibility. So as one, I would suggest as the key move forward to develop more of a cadre of leaders on care programs, something on the sort of paramedic level for neighbourhood care, and which would work between the hospitals, which you haven't mentioned, but they've got a big job in reducing the number of admissions, which home care contribute to. So concentrate on the upper end, the managers, and we need a paramedic profession for neighbourhood care.
I think there are huge opportunities with integration and neighbourhoods, and one of the recent announcements was around nurse prescribers in social care. And I think we'll start to see some of those roles come in more. And I completely agree with your focus on leaders. In the neighbourhood health will flourish where we have good leaders who build good relationships across different boundaries, and we need the kind of hard measures, but those soft measures, good relationships, good values, working towards similar outcomes. That's where we see neighbourhood working now between health and social care, and we've got some examples with Sheffield and Leeds, and that leadership is really important.
Thank you, fascinating talk. And loads of really interesting figures, but the one that stuck in my mind most is the one that said that if you worked in a care setting for 5 years, you earned 7p more than if you started, which is really shocking, isn't it? And I can understand that that's been exacerbated by the increases in the national minimum wage, but it does seem to me to be a hopeless way of rewarding, there must be better ways of rewarding good staff who stay in a care work setting. You mentioned a couple of times something about the care work pathway, and I wondered just if you could tell us a bit more about that. I'm also interested in nurse prescribing, but maybe that's for another question.
The care workforce pathway is a framework that sets out your development as working in care roles. So what skills you need, the competencies you need, but also how you move from here to, you might want to move up into a regulated professional role, or you might want to be a manager, or you might want to specialise in learning disability, or so it just makes those career pathways clearer. My hope is that that will be linked with the fair pay agreement so that we can establish those differentials and not squeeze them. I think that 7p also plays into what we hear about people not wanting to do a qualification. I'm not seeing an impact in my pay from doing a qualification, so why would I? But we do still need to hold on to the fact that people are less likely to leave social care roles than other similarly paid roles. That's a bit of work I think the Health Foundation did, and that's because when people work in social care, they generally really like it, and so we've got to harness that without taking advantage, and we've got to reward people with really good values who want to stay, and I hope that the care workforce pathway linked with the fair pay agreement will be one way that we do that.
Yeah, really great to hear the talk. Because I'm coming at this from an impact perspective. I'm supporting the Real Supply Unit on learning and impact and policy engagement. So I guess a lot of what I hear from policymakers is the type of evidence you're providing. It's the type of evidence that's really useful. It's not necessarily the case that the really sophisticated, advanced thinking and research and evidence can be produced by academics is always going to be useful. It might be a foot in the door, it could be good for conversations, but sometimes it's the simpler stuff that has more impact. I guess I'm wondering what the impact of your work is in terms of influencing change to support all the other relationships and the insights that you have. So like, how does that support change, and what else could academic research or insights add to the type of evidence that you provide to really target some meaningful change? So that might be in relationship to the current opportunity, the consultation out that you said, or other kind of things that are, windows of opportunity for influence just now.
Yeah. I mean, our data set is the data set that is used by government in policy making for workforce. I think it does have a significant impact. When I look back at the white paper, when was that, 2022, which had a big portion on workforce, most of that would have answered this question. So and a lot of the policy initiatives that have carried on even after that white paper, things like the care workforce pathway, well, all of our data fed into that what people don't have is clarity on how to develop, where to develop, the impact of pay on turnover. Well, we're seeing some of that being taken forward with the Fair Pay Agreement, the impact of 0 hours contracts, of that lack of flex, that kind of the balance between flexibility and stability with the Employment Rights Bill. So I think we can see some of that having an impact. It won't be the only thing, it'll be, you know, contribution, not attribution, but what we have been able to do over the last 4 or 5 years, I think, is build more of a coalition around workforce, so that we've got a common understanding of not just the problems but also the solutions. This, you know, sometimes we think in social care we want it to be really, really hard to understand. There needs to be a science behind it, but we want it to be easy to do. You know, a bit like getting fit, or there's going to be an answer and I just need to find it. But actually, it's quite easy to understand, it's just hard to do, and you've got to do it over a number of years. And so I think what we've managed to do over the last couple of years is move workforce and the understanding of both the issues and the solutions into a space where people are broadly in agreement. And I think that will really help then with the policy as we go on in the future. And I can't remember your second question.
I guess it's just, so you've spoken beautifully about the impact of type of work you do.
What can,
So
how can research?
Yeah.
Yeah.
I guess in terms of like the instrumental insights, it sounds like the data you produce is highly instrumentally useful. But you've also mentioned like so much of the work is that coalition building. And so I feel like evidence can often be a powerful tool to convene and bring people together, and to create a shared understanding, even if that doesn't get instrumentally applied in a policy, it's still having an impact in a different way. So I guess I'm just wondering what's the added value opportunities of bringing in academic insights and rigor to that use of evidence.
I mean, I think there's gaps in the evidence that is really helpful to. So in some of the conversations I've had even around this session, and I'm thinking, oh, that's going to be really helpful when we, you know, when that bit's done, and because it adds to the knowledge base. It will help our data. But there's also something about convening. So we spoke about this a little bit with some colleagues, but the opportunity to convene academics, particularly around workforce, to speak to the KC review, for example. Well, that's going to be, things like that are so helpful, because that credibility, that expertise, the confidence that comes from the evidence, and I think we could probably do that more in the policy space to bring some of that together. And in social care, I just think people are so time poor that it's quite difficult for people to keep up with the evidence sometimes. And I don't know how we crack that, but it feels really, really important that we're not just asking all the same questions all the time, that actually we've got some of the answers, we just don't know about them. How do we keep joining that together, and whether we can play a role in helping that, I think I would find really, really helpful.
Great, thank you.
Right, that just leaves us all to thank Oonagh for answering the questions and for delivering a great talk today. So thank you.